In this world we call pharmacology, we have these two topics, pharmacodynamics, pharmacokinetics, right? And we present them like in a sequence, as if that's really what would be happening. But in fact, it's really not what's happening. In fact, pharmacodynamics and pharmacokinetics are happening at the same time. Right? So we've been kind of showing pictures of a receptor, meeting a different type of drug, whether it's an antagonist or an agonist. And that's true, that's going to convey the mechanism or the action of the drug on the body somehow through some receptor-mediated pathway. But through now, we've just kind of ignored the fact that the body's doing something to the drug. Right? The body is, as soon as it sees the drug, is starting to metabolize the drug and eliminate the drug. And so the whole of Chapter 3 is equally important to the whole of Chapter 2 in that it gives you that side of the story, right? It gives you the side of the story of the body and what the body's doing to the drug, which obviously results in a need for subsequent dose. Right? So very rarely will you take just a single dose of a compound, maybe a single aspirin to relieve your headache. But in a regular kind of disease state where you're treating somebody to improve their symptoms, usually they're taking multiple doses. And the reason for multiple doses is because the body is starting to change the drug and eliminate the drug, and the drug's leaving the body. And so you're trying to replace in the second dose what was lost in the first. And so in Chapter 3 we talk about that, and we've kind of been ignoring that so far, but that's also happening. Right? So, in this kind of hypothetical model, and this is kind of somewhere towards the middle or the end of your last slide set. So slide set 3, don't worry, we're going to get to it. I may have even talked a little bit about this, but I felt like I was rushing, so I want to kind of get a few things over. And so when you think about these things coming up to a receptor, they're coming up to the receptor usually in a liquid form. Right? They're being carried by extracellular fluid, just like the ocean carries fish in it. Right? So the drug is coming up to the receptor in a liquid. Most of pharmacology is liquid chemistry. And so some of it will have affinity for the receptor and bind to the receptor. And again, what will dictate that is, what's the concentration that's pumped to the receptor, how tightly it is bind to the receptor. And then when you have a situation of a competition, right, so this idea of competitive antagonism, when you have a competition, right, the two things that are competing for the same receptor. So what's going on in the microenvironment of the receptor? What's around the receptor? Right? If more of one is around the receptor than the other, then the more of one has a higher likelihood of binding the receptor. Right? So that's why in this scenario I kind of made it kind of more simple. And let's just assume that the following situation is occurring. You have two things that can compete with each other. And let's assume that this agonist concentration and this competitive antagonist, which wants to compete with the agonist, but the concentrations at the receptor are the same. And let's imagine that the affinity of these things with the receptor is the same. So similar concentration, similar affinity. And under that stance, similar concentration, similar affinity, we would argue half the receptors would bind agonists and be stimulated, half the receptors would bind antagonists and not be stimulated. Okay, so by introducing this competitive antagonist, we've done something, right? We've tipped the balance. So in this situation, it's still kind of 50-50, right? But in a disease where perhaps an agonist is being, in high level and causing some pathology, we want to compete out that toxic signal with a neutral signal, right? So in that case, you can imagine like smashing your thumb with a hammer and all of the swelling and pain that's associated with that. While some of that is important and good for healing, obviously one of the things that's happening is getting a release of inflammatory mediators. Right? It's kind of like what's happening when you have a headache. You're having a release of inflammatory mediators, right? And so the idea is to block them. And so the way you block them is by out-competing them, right? Using overwhelming force. and outcompeting them. So you drive it towards the right with antagonists and block those receptors. On the other hand, there may be certain situations where you want to overactivate a system, or in fact, perhaps just simply activate the system. Okay, so that would be, one example of that would be hormone replacement therapy. Someone's become deficient in a hormone, maybe due to menopause, or maybe due to pathology of some sort. Right? They're deficient in insulin production, for example, because their pancreatic beta cells are not making the insulin. However, the target cells for insulin are all fine. They're all wired right. They all have their receptors. If only they had the hormone, they could work. So you give the hormone back, you stimulate the receptors, and then you activate those pathways. So these are just some simple pictures to try to maybe conceptualize what's happening when you have an antagonist in the presence of an agonist, or there is no agonist due to some pathology. Now, getting back to this idea of the experimental science, right? Pharmacologists work in vitro and in vivo models to try to understand the nature of a particular compound. How is it working? Is it an agonist? Is it an antagonist? Can it compete? Can it not compete? And so one of the first things pharmacologists study is the effect of various concentrations on the system. So a little bit of drug, a little bit of an effect, a little bit more of effect, eventually you max out the effect. Right? And we've talked about that being a hyperbolic relationship that we can transform to a sigmoidal shaped curve, put the x-axis on the log scale. Now, if we're working with a reversible or competitive antagonist, and we're using a single concentration like you would if you're giving a drug to block something in a patient, right? You're giving them a single dose, giving them 100 milligrams, giving them 50 milligrams, 250 milligrams, whatever it is. A single dose or single concentration antagonist. If it's competitive in nature, we can eventually displace it and overcome. So this gold or this yellow line would be concentration effect curve in the presence of that antagonist. And so what you see is a shift in the curve, right? The EC50 concentration shifts to the right. But at high enough agonist concentration, and I showed you pictures to this last time, high enough agonist concentration, you've competed out with the antagonist. And so your Emax is achievable. Right, so that's by definition a competitive antagonist. If you could overcome its effect and get back to the Emax, consequence is a shift in the curve. But the Emax will not change with dealing with the competitive antagonist. The EC50 is going to change, it's going to shift. But the Emax won't change. And that's going to be different than what we see with an irreversible antagonist. Right, the pattern is very different. So here's a reversible antagonist. We can overwhelm it with high agonist concentration and achieve the maximum effect. But occasionally, the kind of antagonist that's used in the clinic is an irreversible antagonist. Sometimes it's also called non-competitive. Sometimes it's called insurmountable, unable to be surmounted. Right? And so here, when we have an irreversible antagonist, we say that the affinity for the receptor is so high that for all intent and purpose, you can't displace it. And the reason why it's so high is because this is a covalent interaction. So the drug has clamped down and formed a covalent bond with the receptor. This pointer is the receptor, the drug is clamped down covalently. Nothing I can do can take it off. Right? So nothing's going to be able to compete it out because it's lock solid bound. So its affinity, we could say, is infinity. Its affinity is infinity. It's very tightly bound. So how did we even know about these things? Well, experimental pharmacologists discovered that certain antagonists gave you a different kind of graph. Remember the last graph? We saw that the Emax would eventually be reached at high enough agonist concentration. But here's a situation that, again, it's a hyperbolic relationship, not transformed, right? So here we've got our hyperbola agonist alone, a little bit of agonist, a little bit of effect, a little bit more effect, eventually to max out. Now here is the same curve, but in the presence of an irreversible antagonist. So this one's bound to the receptor. So no matter how much drug I give back, as I go from low to high, can I ever get back to the Emax? No, because some of my receptors are now permanently bound. Right, so let's say this concentration of irreversible antagonist binds half of the receptors that are on the tissue. And it ain't coming off. So no matter how much agonist I give, I only get less than my Emax. A less than maximum effect for an irreversible antagonist. For an agonist in the presence of an irreversible antagonist. Now, getting back to this idea of the spare receptor. So up until now, we've kind of said that if you have a tissue that has a certain amount of receptors on it, that usually in order to get the response, all those receptors have to be bound. So maybe the response here is contraction. Right, so if all the receptors are bound, I get the maximum response, right? The maximum response in the tissue. And that is usually what happens. So usually we would say, receptors are not spared. Usually receptors are not spared. But experimental pharmacologists discovered that there are some tissues where you can get a maximum response without maximum binding. It goes against this theory. In some tissues, at very low concentrations, where not all the receptors are stimulated, you can get a maximum response. And so, experimentally, spare receptors are identified. They're identified experimentally at low concentrations, where receptors are not fully bound. So I tried to conceptualize that in this picture. Right? So here's a situation where we've got concentration of agonist, and I'm not really sure what it is, but it's a concentration well below the Emax concentration, right? Because in order to be the Emax, the Vmax, sorry. Right, so concentration versus binding. Right? And usually what we see, a little bit of drug, a little bit of binding, a little bit more drug, a little bit more binding, and eventually we get a Bmax, where all the receptors are bound. And usually the Bmax, when all the receptors are bound, corresponds with your Emax. Right? So usually the concentration of drug that binds all the receptors corresponds to the concentration of drug that gives you maximum effect. So usually the concentration of the Bmax is the same or similar to the concentration of the Bmax. But here I am. I'm at a concentration that's below the Bmax. And how do I know that? Because I don't know how many receptors there are, but are they all bound here? No. So whatever this concentration is, it's not a concentration that binds all my receptors. Would you agree? But yet, it's a concentration that's giving me a maximum response. So when you see something where you're getting a maximum response without maximum binding, that's going to be suggestive of spare receptors. And so if we look at this model, I think I drew 10 receptors. I guess I can count. All right, I drew 10 receptors, and I'm at a concentration that binds 4 of them. Right? So I'm not even at my KD concentration, right? Because for the KD concentration, what percentage of those receptors have to be bound? 50%. Right? So I'm at a concentration even below my KD, but yet I'm getting a maximum response. And so that's depicted here as drug binding to receptor, this little green flap kind of representing a conformational change of the receptor. It might not look like that in real life, but there's some kind of vibration or wiggle or biophysical change that has happened as the drug has bound. That is now sensed by this yellow thing, which is a protein, which we're going to just simply call a coupling molecule. A coupling molecule. A coupling molecule is a molecule that couples the drug binding to the response. It couples the drug binding to the response. Right, so this coupling molecule senses the drug binding and prompts the cell to respond, as indicated here by these arrows. So here I am at a concentration. It's below the Kg concentration to give you maximum response. That's already suspicious. That's like, how can I get maximum response without maximal binding? When I have spare receptors. Okay, so here we go. At this concentration, whatever it is, I'm getting a full response. Experimentally now, if I some antagonist to this set of receptors on a tissue, and that's indicated here by these red circles. And those antagonists bind up some of the receptors. Right? So those antagonists bind but do not activate. If we go back to this model, if we bound up some of these receptors, would we get this full response? No. Right? But here, we bound up a lot of receptors, but yet we still get a full response. So it suggests I could block some of my receptors. In this example, I could block 60% of my receptors, but I could still get a full response. And so now, as I start to increase that irreversible antagonist concentration, now I start to get in trouble because I start to bind some of the receptors that are needed, or some of the non-spare receptors. So at this concentration, whatever it is, I've lost some of my signaling molecules because of inhibition. Right? And eventually I could get a concentration of irreversible antagonists where I've just taken all the agonists away. Now, here's the major difference. If you can remember last class, at this point, we would then come back and overwhelm the system, right, with lots of purple-colored things. And all of the red would eventually be displaced. Do you remember that? Right, that's reversible. But here in this situation, because it's irreversible, because those red things, those red antagonists bind covalently, no matter how purple you bring up to the cells, you cannot displace them. All right, so addition of more agonists will not reestablish the response. This is a very different thing that pharmacologists saw than what they saw for competitive antagonists. So they came up with this idea of non-competitive, or irreversible, or insurmountable. Now again, do you remember which tissue is rich in spare receptors? The heart, right? The myocardium. So it's estimated that up to 90% of the receptors are spare. And so the idea is why? What is the role of spare receptors? And what I tried to show you in those last few slides is that you can get a lot of binding at little concentration. You can get maximal binding at low concentration. And so the presence of spare receptors seems to serve as what we would call an amplifier signal. So back in the day when I used to DJ on the weekends and do parties, I used to have a mixing board. And out of the mixing board maybe came a 3 or 4 watt sound. Right? But if I plugged that 3 or 4 watt sound into an amplifier, now I cranked it up to 200 watts and the walls were shaking. Loud, powerful signal. So we believe spare receptors is something like that. You get the low agonist concentration. You get the maximum response. It's kind of like an amplifier of some sort. If that makes sense. Again, are they the rule? Is that where you find them all over the body? Or just in certain tissue? There's a few places. But when you do these concentration effect curves and you see kind of weird things where you can get maximum response without maximum binding, in the presence of an antagonist, that might be irreversible. That might be a tissue difference. Now, getting back to irreversible antagonists have some consequences because when the receptor gets bound by the irreversible antagonist, it stays bound. So we say that the receptor has become derivatized, right? It's change, it's altered. The drug's not going to fall off. So now if an agonist comes along, does it have a chance at stimulating? No. So if you give somebody an irreversible antagonist, it's like you poisoned the receptor. The receptor can't work anymore. So oftentimes, these kinds of drugs are not therapeutically used because the cell has to often be able to respond again to a signal. So the idea here is with some irreversible antagonists, their use is to poison the receptor. That is their intended use. So one class of irreversible antagonists binds to a molecule in the nucleus called DNA. And what they do is they form adducts with the DNA molecules. These are sometimes called alkylating agents. A-L-K-Y-L, alkylating agents. And I don't know if you've had that topic in MedChem or not. I'm sure you will have it when we do oncology, about chemo drugs. But many chemo drugs work by binding to DNA irreversibly. And so now when that DNA is unwinding and being replicated in the tumor cells, the tumor can divide, the replicational machinery comes along and it gets blocked at the adduct. Can't go past it. Does that make sense? You know how the DNA polymerase rides down the DNA like a Thomas train rides on the tracks? My favorite train. So like my son's getting older now, and he doesn't like watching Thomas Train that much. Come on, it's Thomas, man. Thomas. So Thomas riding down the track. What happens if there's a kink in the track? He gets derailed. Right? He can't continue. Right? So they bring the crane and they right? But in chemo, with alkylating agents, when the DNA polymerase comes down the track and there's an adduct, it cannot continue. So the replication stalls, and the tumor doesn't grow as quickly. So that's one really important class of irreversible antagonists. The other that we'll talk about is a single drug, and it's used in treatment of a certain type of tumor called a pheochromocytoma. And so let me see if I can, maybe that's the next slide. I don't remember. Yeah. So if you look up here and you see this word pheochromocytoma, this is a very rare tumor of the adrenal medulla. Very rare tumor of the adrenal medulla. So you may recall that the adrenal gland is made up of really kind of two functional units. You got a core region that makes catecholamines, like epinephrine and norepinephrine. And two of the older names for that are adrenaline from the adrenal and noradrenaline. Right? So you have the core, the middle portion, and then you have the cortex that goes around the middle portion, which makes cortex cortisol. Right? Glucocorticoids, mineralocorticoids, sex steroids, testosterone, estrogen. So this is a tumor of the middle part. And the problem with this tumor is a lot of people don't know they have it until it shows itself. How does it show itself? Well, pheochromocytoma is a bizarre tumor that spontaneously releases lots of catecholamines. So spontaneously, just, you're walking in Marillac and your tumor releases tons of catecholamines. So all of a sudden you go from being kind of in the rested state to sweating, your heart's beating. It's like you're running in a marathon, right? Your body's under tremendous stress. And the problem with catecholamines is that they're very good at causing increased blood pressure. Right? So the idea is, with pheochromocytoma, what the tumor has done is sporadically released like 100 times more catecholamine than you normally have in your body. So all of a sudden you go from feeling good to feeling really bad. You maybe fall over, maybe you pass out. God forbid you have a stroke, although some people have had hemorrhagic stroke because of this dramatic increase in blood pressure. So we're talking like going from normal blood pressure to something like 220 over 170, in the span of a few seconds. So the idea here is we got this horrible tumor. Why not remove it? Sometimes you can't remove it. Okay. But interestingly, we have this drug called phenoxybenzamine. Phenoxybenzamine is an irreversible antagonist of alpha adrenergic receptors. And probably encountered alpha receptors in medchem and perhaps in AMP. And so we will further discuss these receptors later in the course when we talk about sympathomimetic drugs that stimulate receptors of the sympathetic nervous system. And then inhibitors of sympathomimetic drugs, which are called alpha blockers or beta blockers. So we're going to have a whole chapter on this in our very last lecture. But why does this work, and why do we bring this up here when we're talking about irreversible antagonists? Well, again, if we look at these alpha receptors and kind of try to conceptualize them, they're abundant in the vascular smooth muscle. And so along comes catecholamine, binds them, causing the vascular smooth muscle to constrict. And so if blood vessels are constricted, is it easier or harder to move the blood through the circulatory system? Harder, right? The heart has to beat harder. What about the pressure against the walls of a constricted blood vessel compared to a relaxed? Higher, right? So you got higher blood pressure, your heart's beating harder, the blood pressure goes up. Right? You got vasoconstriction, your heart's beating harder, the blood pressure goes up. Well, that's normally what happens, and that's okay. Like if you're in a stressful moment and you're jogging or you're playing a sport, your body upregulates that system, and that's okay. But the problem is, along comes pheochromocytoma, releasing lots of catecholamine when it shouldn't. That's the problem. And so your blood pressure dramatically increases. This is such a weird tumor that you could actually oftentimes palpate it in the office. The doctor can squeeze it and cause your blood pressure to go up right on the spot. Right? So it's a bizarre one. And so if you use the competitive antagonist to treat this, what would happen? Imagine the release is like a tsunami of catecholamine. Would the competitive antagonist be very effective if you just overwhelm the system with agonists? No. Right? But if you use a reversible antagonist like phenoxybenzamine, which binds to the receptor and blocks it permanently, along comes tsunami of catecholamine, and what happens to blood pressure? It doesn't change. Now, this picture is a little misleading because you don't block every single alpha receptor in the body with the drug, right? Because that would never allow you to raise your blood pressure. So if you were to go from sitting to standing, right, that's a stress on your body, right, like I'm sitting. So, okay, the blood is kind of pooling a little differently than when I'm standing. Gravity's trying to pull it down, right? So gravity's trying to pull down my blood. My smooth muscle is constricting in my extremities to bring it back to my heart so that the heart can pump it to my brain and just pass out. Right? The whole purpose of fainting is if your blood pressure falls too much, your brain's not perfused. And if your brain's not perfused, it lacks oxygen. If your brain lacks oxygen, you get in trouble. Right? So then you faint, so you fall horizontally on the floor, so the blood has an easier time of perfusing. You don't have this vertical stress. That's called orthostatic hypotension. When you go from sitting to standing, we don't feel it usually, but people who take alpha blockers can feel it. So this drug, it ain't all that great because it has some adverse effects associated with it, but it is good for this particular kind of tumor because it's an irreversible drug. Okay, so what's interesting about it, this thing can come up to the receptor in the extracellular fluid, it can bind to the receptor. That which does not bind can keep on going, can eventually end up back into the blood, can eventually end up back into the kidney, and get excreted in the bile, or excreted in the urine, or in the liver and get excreted in the bile. And so it can all be out of your body. But that which stays behind will block. So you can do a blood level of somebody who took a phenoxybenzamine dose a couple hours later, and the drug's gone. You don't see it in the blood. That doesn't mean it stopped working because it is irreversibly bound. So the challenge of that is that the cell eventually is going to internalize that thing degrade the receptor and then make a brand new receptor. That's how the cell will eventually overcome this inhibition. The cell will say, well, it's blocked forever, but I'm going to take it in through endocytosis, degrade it, make a brand new receptor, put it out there in the surface, and then I've overcome it. Any questions on that as an irreversible antagonist? So, we've talked a little bit about antagonists. They can be competitive, they can be irreversible. And we've mentioned agonists, and now I want to give a little bit more detail to agonists. So we could actually classify agonists as either full or partial. So there's two pharmacologic classifications for agonists, full or partial. Now in this picture, the full agonist would represent the purple circles. So the full agonist has bound to all the receptors, and there's a theoretic maximal response that's achieved. In the lower panel, same receptors, same tissue, but now we have an agonist that we would call a partial agonist. It binds to and activates, so it's an agonist, right? Binds to and activates. But look, it gives a response that's less than max. Right, so we say partial agonists stimulate a less than maximal response, even when all the receptors are bound. So here's kind of a conundrum with partial agonists. If you were to look down at the tissue level at the receptors, all the receptors are bound. Yet the response is less than max. Right? If you were to look at binding by the yellow down at the molecular level and compare it to binding by purple down at the molecular level, it doesn't look like there's any differences in terms of how they bind. So then how is it that one is more active than the other? And so what our book goes on to say is that full agonists are more efficiently coupled than partial to the receptor. More efficiently coupled. Don't know what that means. But there's a theory out there to kind of explain it. But what I want you to know is in terms of binding looks exactly the same. But the effect is different, the Emax. And so if you were to do a experimental analysis of this as a function of agonist concentration, looking at the response, a little bit of drug, a little bit of effect, a little bit more effect, eventually I get the maximum effect. So the full agonist is the drug with the maximal effect. If we were to look here at drugs 2, 3, and 4, they all give us a response, but the response is less than max. The Emax for any of these three drugs is less than that what we see for a full agonist. So then if you just take that data and just compare two of those drugs, I've changed the scale a little bit to make them S-shaped curves. Right? But if you were to compare drug 1 and drug 3, drug 1 would be considered the full agonist, drug 3 would be considered the partial agonist. So you might say, then why would I ever use drug 3? I don't want to use a drug that's only going to be less than a maximum response. And the answer is, you work with what you have. Right? You work with what you have. So, God forbid, you end up in the emergency room in Wyoming and you need a special surgery that the person's only done once when they were a resident in Long Island. But you ain't going to survive the flight back to New York, so you work with what you have, right? Hopefully you get a good response. But in this case, maybe all you have is drug-free for patients, because maybe the patient's allergic to drug 1. And if they were to take drug 1, they'd have an anaphylactic response that maybe puts their life at risk. Okay, so a partial agonist, by definition, never achieves the full effect, but it is an agonist. And so, what do we know about these things? Well, pharmacologists have done binding studies for years with these types of agonists. And the types of binding studies are called radioligand binding studies, because we can take a drug and we could put a radioactive hydrogen on it, or we could put a radioactive carbon on it, and then we could put a Geiger counter over it, and we know how much radiation is in a certain amount of tissue. Right, so we can quantify how much drug has bound. We present radioactive drug to the tissue, wash the tissue a lot of times, and that which stays behind has bound. Right? So these are called radioligand binding studies. And so in radioligand binding studies, we can see that there's no difference in binding between the full and the partial. Okay, so we can compete out full agonists with partial. So if we keep the concentration of full agonists steady and we start to increase concentration of partial, you can displace all of the full agonists with partial agonists. The binding is similar. But what have I done in terms of effect? I've decreased my maximum effect because I've replaced with something less than max. So if you were to look at the binding studies, here we have the concentration of partial agonists versus the percent of maximal binding. Here we're starting at 100% full agonist bound. And so as I go from low to high partial agonist concentration, I start to displace full agonists, such that when I'm at this concentration of partial agonists, all my receptors are bound with partial agonists. I've displaced all the full. So I could bind 100% of the receptors with partial. But if I'm to look at effect now, like in the next slide, the curve looks different. So if I'm looking at the effect of the full agonist, when there is no partial agonist, it's max. And as I start to increase my partial agonist concentration, what am I doing to binding? I'm kicking off the full agonist. I'm replacing with partial agonist, right? That was the last slide. But now, what am I doing to response? I'm replacing the full response with a less than full response. Okay, so partial agonist is going to give you a response that's less than the Emax. So then the question is, how can you even have a partial agonist? Because if the binding is the same, how can this be? And so the first answer is, we don't know. That's the answer. The answer is we don't know. But the second answer is, there's a theory that's been put forward that seems to have some credence. And in order to follow the theory, we're going to put something out on the table, and it's not always easy to follow. So the first thing we have to kind of accept in this theory is the fact that drugs can oscillate between two types of structural conformations in the absence of any drugs. They can oscillate between the inactive conformation, or they can oscillate into an active conformation, even in the absence of drugs. But that in the typical situation, this type of equilibrium really favors the inactive conformation. I've drawn that in the next slide. So that most of the time, if you were to look at a tissue, this isn't drawn 99.9%, but 99.9% of receptors will not be active in any given tissue at any given moment. But there's a chance that one of them is active, even though there's no drug. A small, tiny percentage. And why is this? Because molecules have an ability to vibrate around their bonds. Right? So at 37 degrees, which is the body temperature of the human, there's kinetic energy in molecules. Right? You can get wiggling around different bonds. And so the theory is, by chance, a receptor can fall into an active state, even in the absence of drug, because it's kind of been arranged by chance in that correct orientation. And then what happens is a drug can come along and stabilize that active conformation. And that's really how a drug works, that it stabilizes the active conformation of a receptor. That's the theory. So in this situation, if you give a full agonist, by definition, a full agonist only binds to active conformation, stabilizes that, so that full agonist always causes a response. So the purple triangle would bind to the green active receptor and stabilize it. And this would cause the equilibrium to reestablish itself, so that another molecule by chance flips over into the active conformation. And so that another full agonist to it and stabilizes it, and the equilibrium reestablishes. This goes until all the receptors are stable in the active conformation, And this happens tremendously quickly, like on the order of a millisecond. So that you add the agonist to the tissue, and the response happens, and the receptors are activated. But in fact, a certain theory proposes that the drugs really stabilize an active state. And so they keep them active. If you buy that, then a partial agonist has affinity for both types of receptors, the inactive conformation and the active conformation. So that while a partial agonist, the yellow triangle, can bind to this active conformation and stabilize it, it can also bind to the inactive conformation and stabilize it. So that you're never going to be able to get a full response because partial agonists can go both ways. Right? So your response will always be less than active because some of the receptors that get bound and stabilized are inactive. So if you follow this model through, then what does an antagonist do? To which of the conformations does an antagonist bind and stabilize? Only the inactive conformation. Okay, so the idea here is if I look at a partial agonist, if I look at the receptor level with the radioligand binding study, it looks like everything's bound. I'm excited about this too, but I'm pretty much that excited about it too, but I just don't show it. But the thing is, it looks like it's all bound, but some of it might be binding to the inactive conformation, some of it's binding to the active conformation, and changes are too subtle to see with the radioligand study. And so how do we know this might be true? Or really, what was this model originally based on? So this model was originally based on the fact that you can take receptors and grow them on a dish in the lab. Right? You could grow receptors on a dish in the lab, and in the absence of any drug, measure a signal. So there's no drug, but there's a signal. It's a small signal. So if this is the 0 point, then the signal might be like a little bit above 0. So again, it's a tiny fraction of the receptors that are believed to be active without any drug around. And it's kind of a noisy signal. And we call this constitutive activity. Constitutive activity. It means there's always a low level of noise. Like in the old days when you turned on a radio and you heard static, you heard a sound coming out of the speaker, but it was just static. But then if there was a show on the radio and you heard music, it wasn't static anymore. It was a signal. So constitutive activity has been observed for certain kinds of receptors, not all receptors. Histamine receptors, opioid receptors are two that have shown constitutive activity in the lab setting. Not all receptors show this. Many receptors in the lab setting are at 0, but this is where the theory came from. Okay. Now, two more types of antagonists, and we'll be finished with this section. The first are the chemical antagonists. The second are the physiologic antagonists. To put the cart before the horse, chemical antagonists do not block a receptor directly. And physiologic antagonists use totally different receptors to oppose the agonist. So chemical antagonists do not directly block the receptor. Physiologic antagonists use totally different receptor to oppose the agonist. So in the chemical antagonist, there's a situation where our agonist is stimulating a receptor. We add a chemical antagonist, which rather than binding and blocking the receptor, binds to the agonist and pulls it away from the receptor. You see the subtle difference? The antagonist has bound to the drug and taken the drug away. It hasn't bound to the receptor. Right, so that's a unique kind of antagonist called a chemical antagonist. And the example that our book uses of a chemical antagonist is a drug called protamine. Protamine is a protein that's rich in arginine residues. So it's an arginine-rich protein. And arginine has a lot of what kind of charge? Okay. Has a lot of positive charges on its surface. So you got this big protamine molecule with lots of positive charges on its surface. So what kind of chemical do you think it can bind to? Chemical with lots of negative charges on its surface. And so one of the chemicals with lots of negative charges on its surface is a drug called heparin. Have any of you collected blood in the lab in any of your experiments into heparinized tubes? Or do you let the blood clot? Heparin prevents blood from clotting. Right? It's often used in surgical setting, like if a patient's going under some long surgical procedure. And so heparin is an anticoagulant. So what do you think would happen if you gave a person too much heparin? Would they have a blood clot or a hemorrhage? Hemorrhage, right? Because their blood can't clot at all, so you get some damage to a blood vessel and it just spurts out blood. Right? So hemorrhage is a undesired adverse effect of heparin. You don't want to use heparin to the point of hemorrhage. Right? And so if you're a hospital pharmacist and you dispense the wrong dose of heparin, your patient could have a hemorrhage and die. Thankfully, we have an antidote to it called protamine that can mop it up. It can bind to it, drug, and prevent it from acting at its receptor. Does that kind of make sense as a chemical antagonist? Yes, right? Positively charged antidote binding to negatively charged drug, preventing the drug from doing its job. Only in the excess setting. Right, so heparin is an anticoagulant. It's given parenterally. Parenteral means outside of the gut, usually through sub-Q or IV injection. And do any of you work in the pharmacy with an oral anticoagulant? It starts with the letter W. Warfarin. Any of you dispense that one? Right, that one's also got an undesired adverse effect of hemorrhage. But you don't want to get that dose wrong either. And there's an antidote for that, but it doesn't work as a chemical antagonist, and I won't go into it now. So the purpose of this is, do you feel comfortable knowing what a chemical antagonist is? It blocks the response, but not at the receptor level, at the level of the drug that would otherwise stimulate the receptor. If you feel comfortable with that, then the words to that text are here about heparin and protamine. But I've already said the words to you. And so the last topic of this lecture portion is physiologic antagonists. Now, physiologic antagonists use opposing physiological pathways to block the signal. So I'll give you an example. Glucocorticoids released by the adrenal cortex increase blood levels of glucose, right? So glucocorticoids, they do other things, obviously. They're anti-inflammatory and such. But one of the things they do in chronic level, in chronic exposure, is they elevate your blood glucose level. Now, elevated blood glucose levels contributes to diabetes, right? Hyperglycemia. Hyperglycemia is bad long-term, uncontrolled. Imagine taking Coca-Cola filled with sugar and spilling it on the top of your desk there, right? It wouldn't feel too good. It would feel kind of syrupy and soupy and goopy and not happy. That's what hyperglycemia does to the inside of your blood vessels if it's uncontrolled. Right? So what's kind of the things that can happen to diabetics that you don't want to happen in terms of distant body parts? Have you ever heard of amputations? People getting their foot amputated, right? Because the blood vessels in their foot basically stop functioning. and the tissue becomes necrotic. Because after years and years of hyperglycemia, the blood vessels fail. It's as if you had Coca-Cola flowing through you for a long time, right? If you can't control the hyperglycemia. So, glucocorticoids can be a problem for a diabetic patient because although they only increase your blood glucose a little bit in a diabetic patient, they add to the burden of hyperglycemia. Right? So there's one pathway. It works through a glucocorticoid receptor in target tissues. And an opposing pathway would be insulin, a totally different hormone, a totally different receptor. Right? Insulin is the glucose-lowering hormone, or the anti-diabetic hormone. Right? Lowers blood glucose. Glucocorticoids increase blood glucose, insulin lowers blood glucose. Glucocorticoids get released by the adrenal gland and bind to glucocorticoid receptors throughout the body. Insulin gets produced by the pancreas and binds insulin receptors throughout the body. So different receptors. Right? So here, glucocorticoids activate a totally different receptor than insulin, but the responses counter each other. They oppose each other. Right, so this would be an example of a physiologic antagonist using an endogenous regulatory pathway to oppose the effects of another endogenous regulatory pathway. Okay, so a clinician might sometimes administer insulin to oppose the hyperglycemic effects of glucocorticoid hormone in someone who's taking it systemically for inflammation, for example. Now, the last example your book uses as a physiologic antagonist is in the treatment of something called bradycardia. Right? Bradycardia is a type of arrhythmia, but it's an arrhythmia where your heart beats slower than it should. Okay, what's the opposite of bradycardia? Tachycardia. So bradycardia is a dangerously slow heartbeat. And bradycardia is sometimes observed in people who have survived a myocardial infarction. So the good news is you survived. The bad news is you might have bradycardia, which can put you at risk for another heart attack. And so the doctor's going to want to treat that, bradycardia. And so the physician could use a beta agonist called isoproterenol, which is an opposing physiologic system. So bradycardia caused by vagus nerve over-release, increased release by vagus nerve like you see in heart attack, that acetylcholine acts at muscarinic receptor slows the heart down. The clinician might say, well, let me speed the heart up, use beta receptors. The problem is, I wouldn't advise that because isoproterenol has a very narrow window before it becomes toxic. It's a hard drug to work with because it has high toxic potential. It would be a good example of a physiologic antagonist because it's a totally different receptor that has an opposing effect. But the clinician might decide, rather than going with a beta agonist, to go with a competitive antagonist of muscarinic receptor like atropine, which would just reverse the effects of having too much acetylcholine and the heart would speed up. So the book likes this example because it's showing you two different ways to go about this clinical problem. One way is to just use a competitive antagonist, which is probably safer in this patient, by the way. The other is to use a physiologic antagonist, like isoproterenol, and just turn on a different receptor pathway that opposes the effect of acetylcholine. Okay, so are you feeling okay now with the difference between physiologic antagonist, chemical antagonist, okay, partial agonist, full agonist? Okay. So why don't we take like a 3-minute break? We'll start up again at 8:44, and we will start our second topic of the day, which is lecture set 3.